I was just going to start off by explaining a little bit about treatment on the inpatient side, and one of the things are the respiratory modalities that we provide on inpatients. And and you guys have heard a lot about 6-minute walk tests, and I'll just start with that in describing the test. In the pulmonary rehab or outpatient or in the inpatient areas, what we do is instruct the patient, perform a baseline pulse oximetry, and then we explain the test to the patient as we want them to walk as fast as they can for as long as they can without interruption or without slowing down for 6 minutes straight. And we measure the distance that they walk and also measure their pulse oximetry throughout the test as well. And at the end of the test, and we document what the lowest saturation was during the 6-minute walk. And we do encourage the patient to walk, again, as fast as they can and without slowing down. If they do stop, that's fine, and we encourage, we don't want them to walk to the point that they're, endangering themselves by having chest pain, but we do, keep the clock the clock continues to roll for the, when they stop, the clock doesn't stop. So we measure that distance and report it, and it's very useful in noting, their from the Borg scale maybe or some other dyspnea scale to look at what their perceived shortness of breath is or dyspnea during that time is. And the other thing that we monitor on patients that we have an influence in is FVC measurement and spirometry, with looking at spirometry data and making sure from the therapist standpoint that we try to do the best study that we can. And spirometry, or for those who have had it done, they can attest to that pulmonary function testing is quite effort dependent, and it does require, being able to follow some instructions. It's pretty harmless, but it does require a great amount of effort in making sure that we get the best effort from the patient so that the proper diagnosis can be made, and looking at ATS criteria and making sure that the test is not flawed or has some data reported that's skewed because of some patient effort or other limiting factors. So we do monitor those. In regards to oxygen therapy, that's the other, evaluating pulse ox is readily available and monitoring what their oxygen level is, and then also looking at during exercise, does it desaturate or do they drop to less than 88 or 89% or less than or equal to 88%, and then providing them with some form of supplemental oxygen. Usually the most common is a nasal cannula, but room air, as we all know, is around 21% oxygen. So if someone's pulse ox is lower than 89%, or another acceptable or another documented value, say less than 90%, then we would look to provide supplemental oxygen. And usually our first starting point is usually with a nasal cannula at around 1 or 2 liters per minute. But we do other things with in regards to overnight pulse ox trends that allows us to put a pulse ox continuous on a patient and monitor them via inpatient or outpatient, and have them come back and download that data with and it reports out their high, low, their average, and also it tells the time spent with their saturations less than 89%, or and shows some graphical data that is useful for the pulmonologist or the referring physician to look at, is there like sawtooth patterns or something that's maybe seen with some type of obstructive sleep apnea or different other diseases. But the other thing that we do provide is just education to the patient if it's in regards to pursed lip breathing or diaphragmatic breathing, or using accessory muscles, and just answering questions and trying to help that patient if they do have a nicotine addiction, trying to address that with them as well. Unfortunately, we don't, like whenever they had talked earlier, when someone with COPD or emphysema comes to the hospital, we have protocols that we can start with these patients right away, that we know we're going to give them bronchodilators and treat wheezing as a primary symptom or sign that we see. But with a lot of IPF patients, we really look to treat their individual symptoms and try to just evaluate what they need based on that, and try to do some type of inspiratory capacity maneuvering to help strengthen muscles, or some type of positive expiratory device to help maybe with airways resistance, or help to increase some type of alveolar oxygen diffusion.
Hello, everyone. My name is Tina Densley. I'm from Health South Deaconess Rehab Hospital. And at Health South, we are a hospital. And so in order to be admitted into the pulmonary rehab program as an inpatient, we're required to have a physician referral and do a pre-screening for admission. Our patients, once admitted to the hospital, are treated, just as Liesl mentioned in her presentation, with an interdisciplinary team. We have physiatrists on staff who focus on a physiatrist is actually a physical medicine and rehab physician, and we have 3 physicians of that nature at our hospital, and they will admit you and be able to follow you on a medical aspect, as well as being able to guide the rehab team, which also consists of the rehab nurse, the physical therapist, and an occupational therapist, as well as a dietitian, a psychologist, and a rehab counselor. So we look at the entire patient and the entire person to be able to treat you from all aspects of your life. Our program is devised where a person participates in therapy for 3 hours a day. Initially, that may be very difficult for some people because of the debilitation from the pulmonary problem, but the goal is to be able to work up to 3 hours within the first week. Most persons have a lot of problems with being able to walk for long periods of time. So if you have difficulty with taking frequent rest breaks while you're walking, or if it takes you longer periods of time to be able to do your daily activities of living, such as bathing and dressing, cooking. So one of the things that we focus on is endurance and being able to teach you compensatory mechanisms and able to help you perform those activities each day. It's very difficult, and our goal is to be able to help you get back to normal living. So exercise is extremely important, and to be able to maintain your endurance and be able to do those activities. The physical therapists work with each patient on walking and strengthening exercises for your legs. We'll do treadmill exercises as well as bicycle exercises on the stationary bike. The occupational therapist will then work with you on activities with strengthening your upper body and being able to help with endurance. And all throughout this process, we're teaching breathing techniques and things that you can help to be able to conserve energy during these activities. The physical therapist and the occupational therapist work together at times, and we monitor your blood O2 saturations throughout the entire process to see how you do before and after activities and during. We also, with the occupational therapist, have, as I said earlier, upper body strengthening. We use weights as well as the ergometer, the arm ergometer, as well as TheraBand exercises. So the goal is to be able to strengthen upper and lower body, as well as having the respiratory therapist involved with this entire activities. The respiratory therapist will help with teaching how to use medications and inhalers properly, as well as being able to help with administering and doing other education throughout the process.